Okay, let's start. Today topic is diabetes mellitus from Arias 5th edition of static books. Diabetes is a disorder of carbohydrate metabolism. It is caused by combination of hereditary and environmental factors. It's characterized by the inadequate secretion or inadequate action of the insulin. Okay. There is the reason for the rise in the prevalence of diabetes mainly changes in the lifestyle, dietary habits, older age at first conceptions, polycystic ovarian disease, obesity are more so due to the increased awareness, changing methodology in the testing for the conditions. The classification of diabetes pre-gestational or gestational diabetes are uncomplicated or complicated diabetes mellitus. It can be classified as insulin dependent type 1 or insulin independent or type 2. It can be a gestational diabetes mellitus. Other causes like abnormality in insulin receptor, abnormality in insulin axis, disease of the exocrine pancreas, example pancreatitis, endocrine abnormality, example Cushing syndrome, acromegaly, chromosome abnormality, trisomy 21. These are some older classification. No need to remember this thing. Remember, carbohydrate metabolism in the pregnancy. Pregnancy is a unique physiological condition. It is a diabetogenic condition due to progressive increase in the insulin resistance. Okay. Remember the word progressive increase in the insulin resistance causes abnormality in pregnancy. The diabetogenic effect in pregnancy, first is insulin resistance, second is increased lipolysis, third is changes in gluconeogenesis. First in insulin resistance, the production of human placental lactose, cortisol, estriol, progesterone, all these are anti-insulin hormones that will increase in the third trimester mainly, and increase destruction of the insulin by kidney and placenta by the enzyme insulinase enzyme. Okay. Second thing is increased lipolysis. What is lipolysis? The mother utilizes fatty acid, that is fatty acid has to be broken down for her calorie needs, and she store the glucose for the fetus. Okay, so that will cause maternal hyperglycemia. Increased lipolysis, changes in gluconeogenesis, that is alanine and other amino acids that are major gluconeogenic source in the mother is preferentially used by the fetus. Okay, alanine and other amino acids. Pregnancy is accompanied insulin resistance mediated by primarily by the placental secretion of the diabetogenic hormones including growth hormones, corticotropin releasing hormone, placental lactose, chorionic somatomamotropin, prolactin, progesterone. All these are anti-insulin hormone. Okay. What is the effect? If you maintain the maternal glucose high, so that it will be helped to ensure the fetus has an ample supply of the nutrient. In early pregnancy, there is an increased risk of hypoglycemia due to increased insulin sensitivity. Also, the nausea and vomiting common in the first trimester contribute to reduced food intake that may cause hypoglycemia. Okay, the opposite occurs from the mid and second trimester where the insulin resistance start occurring to provide nutrition to the growing fetus. This explains why gestational diabetes is common after 26 of weeks of pregnancy, because the insulin resistance start after mainly in the third trimester, that is mid second to third trimester, the insulin resistance starts. So after 26 weeks, all mothers have developed gestational diabetes. It also explains the increased risk of keto acid in pregnant women with type 1 diabetes also. Complication of the diabetes mellitus. The complications of diabetes mellitus are common in those with uncontrolled, long-standing, fluctuating blood sugar level. This complication may aggravate in pregnancy, hence the risk of pregestational diabetes. Hence, the risk in pregestational diabetes is more. The complication of diabetes could be classified acute and chronic. The acute complications are mainly due to fluctuation in the blood glucose level. There could be either a severe hyperglycemia with a ketoacidosis or a hyperosmolar coma with precipitating factors such as infections and dehydration. There could be mildly symptomatic life-threatening hypoglycemia. The chronic complication occur due to long-standing hyperglycemic state. This causes endothelial damage, lead to small vessels or large vessel damage. If it is a small vessel, that is microvascular, it can be neuropathy, retinopathy and nephropathy. In a macrovascular, coronary artery disease, cardiomyopathy, stroke and perivascular disease. Among the main obstetric consequences of the diabetes are increased risk of preeclampsia, macrosomia and cesarean delivery. There are associated morbidities. Okay. First thing, read in gestational diabetes, as for ACOG, that either commence the glucose any degree of glucose tolerance in any degree of glucose intolerance that either commences or it is first time detected in the during the pregnancy. Okay, these definitions include women whose glucose tolerance will return back to normal after pregnancy, also those who will persist with glucose intolerance and develop type 2 diabetes mellitus. The latter group may also include those women who had unrecognized type 2 diabetes prior to pregnancy. ADA defined gestational diabetes as diabetes diagnosed in the second or third trimester of the pregnancy that was not clearly about diabetes prior to the gestation. But ADA has specifically told, but ACOG told any time at the time of first time if he got diagnosed, it will GDM. ADA told if it is diagnosed in the second and third trimester, it is called a GDM. It should not be a prior pre-gestational. The incidence of this condition, the incidence condition increasing, reflecting the increased prevalence of obesity, metabolic syndrome, the trend towards older maternal age, adoption of modern lifestyle, changing eating habits, reduced physical activity may all contribute towards the increased prevalence of GDM. Family history of diabetes, past history of gestation GDM, ethnicity such as non-Caucasians, Asians, African Americans, Mexican Americans, American Indians, all these are high risk factor for GDM. Risk associated GDM almost the same as those pre-gestation diabetes. The one more important difference is the majority of women diagnosed GDM with normal glycemia at the time of the conception. Hence, the risk of structural congenital anomalies in the fetus may not be developed if the patient has GDM because they have a normal glycemia at the time of the conception. If it is a pre-gestational diabetes, they don't have a normal glycemic control, so they develop structural congenital anomaly if it is a pre-gestational diabetes mellitus. If it is normal GDM, no, there is very less chance, very rare chances of developing congenital anomaly. Okay. The IED PSC 2010 recommended new terminally diagnosed cutoff for GDM based on the hyperglycemia HAPO study. Okay, the cutoff 75 growth 24 32 weeks gestational age, more than 9 centile of the gestational primary cesarean section, clinically diagnosed. The criteria for the diagnosis of over diabetes, any one of the following: fasting plasma glucose. If it is fasting plasma glucose came at more than 126 mg per deciliter, HbA1c is more than equal to 6.5% on the standard is assay, random blood glucose more than 200 mg per deciliter, along with confirmation by fasting glucose or glycosylated hemoglobin level. Okay. How the screening done? Now the most elaborate regimen included either fasting or random blood glucose during the first visit, a screening glucose challenge test at 24 to 28 weeks followed by OGTT. The result outside normal limit indicates a high suspicion to itching. Okay, these are all the low risk mortalities, high risk based on the you do all this test. Previous all these guidelines they told. This is for again ADA and IDFCs recommend one-step diagnostic 75 gram 2-hour HTT. The cutoff for OGTT as follows: if the fasting blood glucose should be more than 92 mg per deciliter, post 1 hour 120 AC, post 2 hours 153. These are some studies. Effect of diabetes on pregnancy. Both pre-gestational as well as gestational diabetes pose many risks to the mother and the fetus. The consequences related to the maternal effect and fetal morbidity. First, we will read about maternal effects. As previously mentioned, diabetes result in number of macrovascular and microvascular complications. These are mainly seen in patients with long-standing pre-gestational diabetes. The severity of this complication vary with the duration and the severity of abdominal glucose level. In pregnancy, there may be acceleration of the end organ disease such as retinopathy, nephropathy. There may be risk of death due to diabetic cardiomyopathy. One of the most severe complication of GDM is the increased risk of developing preeclampsia. Preeclampsia occurs in around 10% of the patient with GDM. Study have now shown that GDM patients have developed preeclampsia in were younger, nulliparous, obesity, gain significantly more weight during pregnancy. The problem arises especially in case of known diabetes with nephropathy, where proteinuria is already present. The risk of superadded preeclampsia is around 35 to 60% in women who have a microalbuminuria in early pregnancy. Okay. Other complications of diabetes include preterm labor, chorioamnionitis, polyhydramnios, urine tract infection. These are the very, very important things you have to remember: preeclampsia, preterm labor, chorioamnionitis, polyhydramnios, urine tract infection, and others. The steroids and tocolytics such as beta-2 agonists given in the case of preterm labor worsen the hyperglycemia and can predispose to ketoacidosis in case of uncontrolled diabetes prior to pregnancy. Risk of recurrent pregnancy loss also increase. Condition during the antepartum period such as febrile illness, dehydration from hyperemesis, diarrheal disease can precipitate all these conditions. The ketoacidosis can be life-threatening not only for the mothers but also it can cause sudden fatal death. Okay. Reports says 4 to 5 maternal mortality from ketoacidosis. Increased need for hospital admission, either insulin therapy during the intermittent illness. Recurrent hyperglycemia episode. There are also first early second trimester patient with pre-gestational dependency in therapy. In patients with pre-existing diabetes, there is an added risk during the pregnancy of worsening end organ damage. So, a particular importance of nephropathy, retinopathy, cardiovascular disease. Neuropathy may manifest just in the form of gastroparesis, resulting in increased gastric emptying time. Renal disease develops in around 25 to 30% of women with insulin-dependent diabetes, long duration around 14 to 16 years. Okay. These are some stages: microalbuminuria, macroalbuminuria, end-stage renal disease. Microalbuminuria, albumin creatine ratio more than 3.5 mg per millimole, or 24-hour urine collection showing albumin excretion 20 to 190 microgram per minute, or 30 to 299 mg per 24 hours. Okay, if it is albumin creatine more than 30 is macro, 30 mg per millimole is macroalbuminuria, or urine albumin concentration is 200 mg per liter or more. End-stage renal disease. In this staging followed by ADA, diabetic nephropathy, stage 1 to be silent, be present in the patient throughout the life without being symptomatic. In this stage, physical exercise may unmask the albuminuria. Further progression, renal disease, damage, glycemic control, renal insulin therapy prevented by. The drugs are contraindicated like AC inhibitor during pregnancy as they assist the fetal proximal renal tuber dysgenesis and oligohydramnios. Alternative drug therapy like labetalol, alpha methyl must be started as soon as the pregnancy got diagnosed. Similarly, background or mild non-proliferative retinopathy should be screened for and fall off during the pregnancy by a dilated fundus examination in all cases of gestational and pre-gestational diabetes. In non-diabetes, fundoscopy is recommended prior to the conception, at first antenatal visit and again at 28 weeks if previous examinations are normal. So remember, when you have to do a fundoscopy, if you have pre-gestational diabetes, you have to do a preconceptionally, and you have to do it at first antenatal visit, again at 20. Remember, you don't forget, again at 28 weeks you have to do repeat fundoscopy if it is normal previously. Also remember these things. In case any pre-existing lesion, repeat examination should be done at 16 to 20 weeks. Non-proliferative stage of retinopathy can be managed by observing good glycemic control. In case of it is a proliferative stage and you have to go for a pan-retinal photocoagulation can be done. Diabetic macular edema needs to be controlled by focal or grid laser therapy. Diabetic retinopathy is not a contraindication. Remember, diabetic retinopathy is not a contraindication for vaginal delivery. Remember, this is a very important question in your exam. Remember, don't forget, not a contraindication for a vaginal delivery, diabetic retinopathy. But in case of proliferative retinopathy, that is if it is untreated, the labor may be result in increased intraocular pressure that will cause a result in intravitreal hemorrhage due to rupture of the fragile vessels. Hence, such patient may be identified and treated, and decision regarding mode of delivery for each patient to be individual. But if it is a more chances on treated, ophthalmic follow-up for at least 6 months after delivery is recommended in case of proliferative retinopathy. Intrapartum, there may be increased need of intervention, chances of infection, need for operative delivery, either instrumental delivery or cesarean section. The need of cesarean section arises due to dysfunctional labor, macrosomic baby, prolonged labor, apart from other obstetric indication. In postpartum period, there is risk of postpartum hemorrhage, infection, puerperal sepsis, the long-term risk developing cardiovascular and type 2 diabetes, renal disorder, diabetes in pregnancy. Okay, then fetal and neonatal lipid. The main fetal risks are growth abnormality, chemical imbalance, growth abnormality, macrosomia, growth restriction and malformation, chemical imbalance after birth, fetal oxygenation problems, sudden fetal demise, chronic fetal hypoxia, respiratory distress syndrome, long-term sequelae. The growth abnormality, the disorder fetal growth is a problem of all type of maternal diabetes. The macrosomia defined as a fetal weight. Remember, macrosomia, fetal weight more than 19th centile for that gestational age, or estimated fetal weight if it is estimated fetal weight more than 4 kg, more than equal to 4 kg is the commoner abnormality. Okay, remember, if the fetal weight is more than 90th centile for that gestational age, or estimated fetal weight equal to or more than 4 kg, that is called as a macrosomia, is 4 kg. The macrosomia result from maternal hyperglycemia, that is Pedersen hypothesis, that will lead to excess transplacental glucose transfer which in turn cause fetal hyperinsulinemia. This affects in only after 20 weeks of gestation when the fetal pancreas got developed. When fetal pancreas will develop? After 20 weeks, the islet cell get activated. Islet cells are get capable of secreting insulin in response to hyperglycemia. It suggested that intrinsic fetal pancreatic beta cell hyperplasia assists in maternal glycemic control. Insulin-like growth factors cause excessive fetal growth and deposition of subcutaneous fat in the baby. Some suggest that this results in a larger fat in the shoulder and trunk region, causing shoulder dystocia. Subsequent birth trauma to the fetus, such as clavicular fracture, brachial plexus injury, as well as the mother. There is also occurs a fetal hepatomegaly, splenomegaly, cardiomegaly due to hyperinsulinemia. The projective predictive for detection of macrosomia is greater than 90% with the abdominal circumference. Remember, the abdominal circumference is more than 95th centile. The projective macrosomia is 90%. ACOG says that if the gestational diabetes remains undiagnosed, onto the risk of macrosomia as 20%. In case of pre-gestational diabetes, prolonged duration wherein there is an evidence of systemic vasculopathy, there is risk of uteroplacental insufficiency. Uteroplacental insufficiency lead to intrauterine growth restriction. This vascular insufficiency occurs maternal hypertension. Before 20 weeks, fetal islet cell are not well developed. Thus, the main culprit of the high glucose level is the main culprit, not the fetal pancreas hyperinsulinemia. Exposed to the high glucose level at the time of organogenesis result in number of fetal malformation in those with uncontrolled pre-gestational diabetes. 50% of the anomaly affect the CNS and cardiovascular system. Following anomaly is CNS, CVS, skeletal, renal, and intestinal. CNS neurological defect including anencephaly, meningocele, meningomyelocele, encephalocele. In cardiovascular, ASD, BSD, transposition of Gator's artery, and hypoplastic left heart. Skeletal caudal regression syndrome, spinal anomaly. In renal, hydronephrosis, renal agenesis, cystic kidney, intestinal duodenal atresia, and anorectal malformation. Maternal glycogen hemoglobin level in the first trimester may be helped to predict the risk of occurrence of congenital anomaly in the fetus. In case of pre-gestational diabetes, studies show that HbA1c is less than 7%, there is no greater risk of anomaly than non-diabetic mothers. If it is 7 to 8.5%, the risk is 5% of an anomaly. If it is more than 10%, the risk is 22%. Okay. Okay. Preconceptually, the patient should be, how you counsel the patient preconceptually? The patient should be counseled regarding the risk of anomalies. Remember, the patient should be counseled the risk of anomaly on the basis of patient should be counseled regarding the risk of anomaly on the basis of the hyperglycemic control. In case of high HbA1c level, the decision regarding the continuation of pregnancy and the patient discussion screening of anomaly must be done by ultrasound. The most congenital anomaly occur early in the gestational conditions. A condition called the small left colon syndrome may be seen in second half of the gestation, especially in the type 1 diabetes. In this, there is a uniformly small diameter of the descending colon and sigmoid colon and the rectum. Uniformly small, that is small left colon syndrome. The most congenital occur in early gestation. Small left colon syndrome. Okay, remember this thing. The hyperglucagonemia occur in response to decrease in fetal glucose level, causing intestinal hypomotility. Intestinal motility is main factor for stimulating intestinal growth and differentiation. A neonate with small left colon syndrome may present the intestinal obstruction, may mimic meconium plug syndrome. Okay, so these are the things. Hyperglucagonemia occur in response to decrease in fetal glucose level, causing intestinal hypomotility. Intestinal motility is a main factor for stimulating intestinal growth and differentiations. Hyperglucagonemia, fetal chemical imbalance, fetal hypoglycemia due to maternal hypoglycemia can result in sudden intrauterine fetal death. Neonatal hypoglycemia occur due to hyperinsulinemia in the fetus and the removal of the exogenous glucose source maternal at the time of delivery. Hence, after delivery, the maternal source of glucose is lost, so fetal hypoglycemia, neonatal hypoglycemia occur due to hyperinsulinemia also, and also due to the removal of the exogenous glucose source from the maternal at the time. Hence, this baby are closely observed. Other chemical imbalance in a neonate of diabetic mother, hypocalcemia. Remember this hypocalcemia and hypermagnesemia with occur within 72 hours after. Within 72 hours of birth. Hypocalcemia occurred due to delayed postnatal parathyroid hormone regulations. Pathophysiology of which is still unclear, the hypocalcemia, and this affect individual at the birth asphyxia. The cause of hypomagnesemia is similar to that of calcium metabolism in the neonate. It could also occur due to long-standing diabetic nephropathy in mother, leading to maternal renal magnesium losses. Hence, it reduces availability of magnesium for the fetus. Okay. So, risk of neonatal hyperbilirubinemia is increased due to preterm delivery, ineffective erythropoiesis, expanded red cell mass, relative immature hepatic bilirubin conjugation and excretion. Study have shown that around 65% of infant of diabetic mothers have abnormality of iron metabolism due to accelerated erythropoiesis. There is a deficiency of iron at tissue level indicated low serum ferritin level. Iron deficiency increases the risk of neurodevelopmental behavior abnormality. However, this may be not anemic. Spontaneous recovery from the iron status has been documented. Iron metabolism abnormality is there also in the diabetic patient. The fetus also develop anemia, mother also develop anemia. There is also risk of respiratory distress syndrome due to surfactant deficiency. Babies of diabetic mother are prone to this complication due to increased risk of preterm delivery, also acute late maturation of the type 2 alveolar cells. Fetal hyperinsulinemia is the antagonist. The antagonize the action of the cortisol, causing blunted the production of the surfactant. Okay. Fetal oxygenation problem. Fetal hyperglycemia and hyperinsulinemia increase the rate of oxygen consumption by around 30%. Fetal hyperglycemia, hyperinsulinemia increase the rate of oxygen around 30% in relative oxygen limited environment. Though fetus increase the substrate intake, there exists some degree of oxygen deficit. This further accelerates the placental vasculopathy. Chronic hypoxia results in excessive erythropoietin secretion, fetal kidney, causing accelerated erythropoiesis. This results in neonatal hypolycythemia and hyperviscosity. This may cause neonatal stroke, seizure, necrotizing enterocolitis, sudden fetal death. The degree of maternal hyperglycemia correlate with severity of polycythemia. Okay. The degree of the studies on the amniotic fluid and cord erythropoietin as a marker of fetal hypoxia. Neonatal hyperglycemia, hypertrophic cardiomyopathy, admission to intensive care unit occur in those with higher amniotic fluid erythropoietin level. Found to be 14 milliinternals in diabetic pregnancy. Sudden intrauterine fetal death associated with diabetic pregnancy, which is difficult to predict by any kind of antenatal fetal surveillance. Umbilical artery Doppler can detect placental insufficiency, which could be a cause. However, in the absence of vasculopathy, prediction of sudden fetal death is almost impossible. Though amniotic fluid erythropoietin level indicate hypoxia fetus, the feasibility of use of this parameter is still under study. Moreover, it may not predict when a fetus succumb. Various explanations of sudden fetal demise have been proposed, like include maternal hypoglycemia, ketoacidosis, and chronic hypoxia, placental villus edema impairing nutrition transfer. What are the long-term sequelae? Baby born to diabetic mother have the risk of developing obesity, type 2 diabetes mellitus, cardiovascular disease, impair cognitive motor function. This can due to combination of factors including genetic, inherited, intrauterine parental asphyxia, abnormal glucose, magnesium metabolism, iron deficiency. Management options pre-pregnancy. Women with the reproductive age group with diabetes should undergo a complete health checkup, pre-conceptual counseling prior to the planning of the pregnancy to achieve optimal glycemic control. Okay. Women with reproductive age group. Okay. Contraception must be used to prevent unplanned or unwanted pregnancy. Appropriate dietary measure, exercise, weight loss, drug therapy, oral hypoglycemic agent, insulin can help achieve optimal glycemic control. Renal cardiovascular functions, retinal assessment, digital imaging using mydretics such as tropicamide must be done to detect end organ damage. Accordingly, total therapy must be targeted to achieve pre-pregnancy HbA1c less than 6.1%. Target is less than 6.1%. Okay, remember this. This would likely reduce the congenitally if avoid pregnancy. All OHA except metformin should be stopped before pregnancy, and insulin must be substituted. Rapid acting insulin, aspart. Rapid acting insulin, that is rapid acting insulin is Lispro and aspart. Intermediate action is safe. Insulin is intermittent insulin, however, there is insufficient evidence the usual long-acting insulin. Metformin continued. Other drugs, acetaminophen, angiotensin, antidiabetic management. Antenatal recent data provide evidence that early initiation of therapy for diabetic helps in improve outcome. Reduce the adverse effect. There is also evidence of ADA recommend fasting target is 95, 1 hour is 140, 2 hours is less than 120. EC is less than more than fasting. Postprandial 100 mg, 75% fasting. Okay, self-monitoring of blood glucose. The SMBG is required to identify those patients where intensifications of treatment is needed. Initially, the SMBG may be required to done by as many as 6 to 7 times a day, which may then be reduced to 3 times. Usually, practice reduced to 3 times. Usually 3 times. Then be reduced to 3 times. Usual practice to perform fasting glucose in 2 hours after lunch and dinner or before meal on alternate days. Though fasting glucose alone does not predict need for initial insulin therapy, HAPO study have demonstrated increased adverse perinatal outcome. Elevated fasting glucose level alone and OGTT. A glucose level must be done at 3 am to document nocturnal hyperglycemia, which may occur due to excess bedtime insulin during fasting hyperglycemia phenomena. Nocturnal hyperglycemia because fasting hyperglycemia. In case of fasting hyperglycemia without nocturnal hyperglycemia, it's called dawn phenomena. The cause which is not known. The recurrent increase in the bedtime long-term acting insulin. The two phenomena you have to remember: the dawn phenomena and the Somugai phenomena. The dawn phenomena is there will be a fasting hyperglycemia without any nocturnal hypoglycemia, and in the Somugai phenomena. In dawn phenomenon you have to increase the dose because there will be a hypoglycemia and nocturnal hypoglycemia. This recur and increase the cause which is unknown. This recur and increase the bedtime insulin dose taken into consideration. In Somugai phenomenon there is without glucose there will be nocturnal hypoglycemia, that will be fasting hyperglycemia. So you have to decrease. Taking into consideration target glycemic control, the degree of glucose in the medical nutrition therapy. We have to first line therapy for women with GDM and is dietary modification. The must be done consider the nutritionalist. Taking into account therapy, BMI is less than 25, 3000 calorie. Overweight, BMI 25, 30 to 1500. Morbid obesity, 12,550 calorie. Okay. Index insulin therapy, exercise, glycine, pharmacotherapy, insulin. Insulin therapies remain the gold standard in the treatment of GDM and pre-gestational diabetes. Most association is recommend on the use of short-acting regular insulin. Short-acting regular insulin is onset of action is 30 minutes, lasting for 6 to 8 hours. Intermediate acting neutral potamin, hexaton, NPH insulin action is 1 hour and lasting for 10 to 40. Recent research added new rapid-acting insulin Lispro and aspart whose action begin within 15 minutes. All study on the use of glargine is that was no increase adverse outcome compared to NPS. However, glargine lantus has still not been recommended for use in pregnancy because concern regarding mitogenic action because it causes increased fetal growth due to high affinity insulin growth factor receptor 1. The requirement for insulin increase with gestational age, glycemic control, obesity other factor. Dose of insulin vary 0.6 to 1 unit per kg body weight. Per day in divided dose depending on the trimester of the pregnancy. ACOs recommend the insulin therapy for those who are not able to achieve glycemic target mentioned in the previously medical nutrition therapy. Commonly used formula for insulin therapy is you have to calculate the total daily dose requirement to divide the total daily dose into 2/3 in the morning and 1/3 in the night. Out of the 2/3 morning dose, you have to divide again morning dose 2/3 in the 2/3 to NPOs, 1/3 to short acting. And again in the pre-dinner dose, 1/2 NPS, half short acting. Insulin started if glycemic control is not achieved with MNT. The aim is to maintain the fasting is less than 95, post 1 hour is 130 to 140 and post 2 hours is less than 120 mg per deciliter. The patient need to be taught self-administration of insulin and be warned against the hyperglycemic sign. In case of a recurrent hyperglycemic episode, insulin dose require readjustment. Patient may be offered continuous subcutaneous insulin infusion pump therapy. The insulin dose need to be adjusted according to the glucose level, especially in the emergency cases such as ketoacidosis in labor, post-operative period during management of preterm labor due to hyperglycemia, effect of beta emitting steroid. Apart from hypoglycemia, administration of insulin may be associated with complications of infection, pain at injection site, lipodystrophy, compliance problem with insulin therapy to the daily multiple injection required. How hence any patient on insulin must be strictly observed. Okay. Then oral hypoglycemia for those patients who are not willing to use insulin, who are non-compliant to OHA has been used in pregnancy. One is metformin, another is glyburylate supplement group. In the past, there is concern regarding the teratogenicity, though not recommended by most of the clinicians. Use of OHA become popular in clinical evidence. It has been started preconceptually for obesity, PCOS. The NICE guidelines suggest metformin during pregnancy if the benefit out of the potential is comes with the drug. Metformin MIG trials show that use of metformin in GDM patient reduce required dose of insulin dose, also reduce the total weight gain. There is however no difference in the perinatal outcome. Patient acceptability was better. What is MIG trial? If MIG trial is telling if you use metformin along with insulin, it will reduce the dose of requirement of the insulin. There is however no difference in the parental outcome. The patient acceptability was better. Similarly, though evidence suggests that glyburylate in the dose of 5 to 10 mg BDSA per in the fetus, it did not have any advantage over insulin treatment GDM. There have been hardly studies that combine effort between GDM. Maternal and antenatal management also include identification anemia, urinary tract, vaginal tract infection. Since asymptomatic bacteria candidiasis are very common in diabetes, the thyroid function stage should be evaluated. Women with pre-gestational diabetes must be screened by various investigations for end organ damage like pendoscopy, serum creatinine, 24 unit protein, ultrasound, KUB, ECG, echocardiography, frequent and visit monitoring fundal weight, recording blood pressure, asking the patient general well-being, fetal surveillance, postmortem early ultrasound for confirmation of the viability. Dating must be done. This help in later confirmation of the gestation is in preterm cases for planning at the time of delivery. First trimester screening including maternal serum, Papa A, and beta ICG with ultrasound evaluation for detecting chromosomal anomaly in the fetus must be upward between 11 to 14 weeks of gestation. Age diabetes percent does not increase the risk of chromosomal abnormalities. However, many of these patients are elderly, which may produce normal anomaly, chromosomal anomaly. Nuchal translation more than 3.5 is associated with cardiac anomaly in chromosomal anomaly fetus. Cardiac anomaly combines with diabetes, hence NT is an important marker. Also, ELI scan 11 to 20 weeks, 12 weeks detect neural tube defect, that is in diabetes. Second trimester detailed scan for anomaly must be done between 18 to 20 weeks. Being experienced sonolysis, maternal serum alpha protein level also increase in NTD. However, there is no added benefit if the anomaly scan is normal. Fetal echo at around 44 weeks as a routine in all diabetic patients may not be cost effective. Major cardiac anomaly can be detected, especially those with conotruncal septum defect, by the fourth chamber outflow tract view on ultrasound. Thus, fetal echocardiography might be justified when the diabetes with increased NT in the first trimester with a normal karyotype, when a cardiac anomaly is suspected in the anomaly scan, when the cardiac visibility is restricted on ultrasound due to maternal obesity, pre-GDM with poor glycemic content in the first trimester. In case of diabetes complicated with hypertension or restricted fetal growth, in cases of diabetes complicated with hypertension or restricted fetal growth, umbilical Doppler should be done fast as uteroplacental insufficiency. Subsequent Doppler study help to predict prenatal outcome. Plan of subsequent management in the absence of risk factor, umbilical Doppler is significant predicting adolescence. Third trimester, nicely suggests 4 weekly monitoring fetal growth restriction from 28 to 36 weeks. Help to detect macrosomia, polyhydramnios, associated the accuracy ultrasound diabetes suspected macrosomia similar to clinical palpation or leopard. Diabetes method must be explained the importance of daily fetal count, which is easy and expensive non-invasive method for fetal well-being. Any reduced midnight must be immediately put in district of mother. Press the polyhydramnios, suspicious difficulty in fetal movement. Biophysical profile take into consideration fetal movement, breathing tone, amniotic fluid, largest vertical pocket, non-stress test. A good BPP score is reassuring. However, it cannot predict adverse parental outcome or sudden fetal death. In women with well-controlled diabetes, no complication, the value of antenatal fetal well-being test is questionable. In case of hypertension, vasculopathy, depending on the severity and the frequency of the tests will vary. If the frequency goes beyond 38, then weekly, biweekly intense fetal monitoring with modified BPP does seem appropriate. The timing and mode of delivery, although most association recommended delivery after 38 weeks of completed gestational is in diabetic patients, some state that uncomplicated cases gestational diabetes not pre-gestational may be allowed to wait for spontaneous labor up to 40 weeks with adequate fetal surveillance. The main concern with the vaginal delivery is the risk of shoulder dystocia due to macrosomia. However, it has been seen that 50% cases of brachial plexus palsy occur in the absence of shoulder dystocia. The ACOG in Iceland suggests that vaginal delivery is not contraindicated for suspected macrosomia. That estimated fetal is more than 4.5 kg. In the Indian population, the baby weight is less. Biology of the study 3.4 kg. Vaginal delivery should be allowed for a proper assessment. Pelvic adequacy depending on the biceps labor can be induced with mechanical method of prostaglandin or substitution. The suspected macrosomia also not a contraindicated for vaginal delivery. BBS season section. Management during labor, consent can be taken, explaining the high risk need for instrumental delivery, cesarean sections if required. Whole blood gas mask kept available on the evening prior to the induction. If indicated, insulin dose has to be given, meal are taken by the patient. Morning dose of insulin has to be omitted, and fasting blood glucose should be done. Aim to be skip glucose level between 70 to 126 mg per deciliter. 2 IV line must be secured. If the blood glucose level not maintained, then dextrose insulin neutralized dips to be started. 50 units of regular insulin is 50 ml hours, and those are adjusted to the glucose level. Then the 10% 50 ml of normal 50 units. 10% of dextrose drip at the rate of 125 ml per hour is continuously given through the other line. It is important to monitor vitals, fluid intake, output, urinary kittens, blood flow every 1 to 2 early. Fetal heart rate must continuously monitor the partograph charted active labor. Labor analysis can be upper care must be taken to the second stage. Instrumental delivery must be undertaken with care. Most traumatic and returning PPH must be watched for. Baby should be evaluated for immunology. Precaution during cesarean sections. Elective cesarean section for macrosomia is recommended by diabetic pregnancy if the estimated fetal is more than 4.5 kg. Anesthesia must be consulted prior to the elective cesarean delivery. After appropriate consent, blood availability, light meal, night dose of insulin are given. Elective cesarean sections, diabetic mothers should be preferably performed as the first case in the morning as the patient is fasting and there is availability to all necessary personnel. Morning insulin dose should be omitted and fasting glucose should be done. If required, sliding cells of insulin can be started. Continue the post-op period. Severely obese require thromboprophylaxis may require special precaution while performing the sections are adequate. Incision size to allow delivery of the big baby. Use a forceps to deliver the high floating head. To check for a suture extension or uterine incision which may take place especially while performing second cesarean section. Post-op glucose monitoring must be continued. Patient mobilized as early as possible. In postpartum management in GDM, the need for insulin after delivery reduces. It can be stopped if the glucose level are within normal limit. The pre-gestational diabetes must be continued on insulin for a while and then can resume their pre-gestational medication. Once the patients resume full diet by the third day after delivery, fasting and post-lunch glucose level can be done. And subsequent therapy decided. Wound care is important as there is high chances of infection in the diabetes. Prolonged antibiotic therapy must be given, especially in the case of complicated cesarean instrumented delivery. The ASU is recommend testing all cases of GDM 6 to 12 weeks postpartum to provide no with the glucose levels. Otherwise, fifth intelligence conference 70 rigidity with GDM 6 to 12 weeks postpartum. If it is normal, then 3 yearly assessment should be done. Impairing both immunity for the required management of diabetes ketosis more complex in case of type 1 diabetes, ketoacidity, precipitate conditions, excess stress, diarrhea, infection, preterm labor, others. The life-threatening condition mother actually diagnosis of ketoacidity is made when blood glucose level is more than 250 mg per deciliter. It may occur at lower level also in pregnancy. Ketone body is also in blood and urine. Arterial pH is less than 7.3 and the serum bicarbonate level less than 15 milliequivalent per liter. What is the pathophysiology? Stress resulting in gluconeogenesis, aggravating insulin resistance. Fatty acid is used, ketone body is produced, acetic acid, acetone beta hydroxybutyric. The hyperglycemia due to underutilization and overproductions. Osmotic diuresis causes dehydration, maternal fetal distress. Metabolic acidosis, ketonemia, ketonuria, ketone gives switch disorder to breathe. Metabolic acidosis, compensation hyperventilates, cause small breathing, maternal and fetal distress. Initial laboratory assessments should be blood glucose, serum urine ketones, blood glass, urine serum ketones, urine ketones, blood glucose, blood glasses, electrolytes, empiric blood count, ECG, chest X-ray. Periodic monitor, pulse, blood pressure, input, output checking, capillary blood glucose, urine ketone, blood gases. Fetal heart monitoring, fluid replacement, severe dehydration may result in large fluid deficit as much as 6 to 7 liters. The estimated fluid deficit must be replaced around 12 to 24 hours. In the first hour, 1 liter of normal saline is infused followed by 300 to 500 ml per hour till pulse blood pressure back to normal. Hypokalemia generally occur in diabetic ketoacidity if it is less than 4 milliequivalent per liter. 30 milliequivalent per hour KCl must be given when the level is more than 4 milliequivalent per liter. The amount of KCl infused to reduce to 10 to 15 milliequivalent per hour. Insulin therapy start as soon as possible and intravenous bolus 0.2 unit per kg followed by 0.1 unit per kg per hour for normal saline. If the blood glucose doesn't fall by 30% in the past 3 hours, the drips rate should be double. Once the glucose level between the 200 to 250, the normal saline is changed to 5% dextrose. Bicarbonate administration is required if the pH falls less than 6.8. Antibiotics should be given. Treatment of the cause is important. Contraceptive outpatient should be counseled regarding the contraception. Barrier method is an ideal method. Progesterone only if it is also safe. Combined oral contraceptive pill may be best to avoid, especially if the pre-gestational diabetes, chronic long duration diabetes. Intrauterine device may produce infection. A diabetic patient may undergo tubal sterilization with precaution. Counseling of the husband for vasectomy also good options. Thus, diabetes management in pregnancy has evolved over the past year due to challenging lifestyle increasement and obesity as delivery. Due to this thorough knowledge regarding the best possible therapy, the patient treatment has to be individualized. Gestational diabetes in Indian perspective. India has called the diabetic capitals of the world with more than 43 million diabetic in the country. Lot of these women in the childbearing is consider the Indian population disease guidelines. Screening diagnosis explained previously. Significant increased people abortion study under duty. Important point.